So let us start with the first day. Good morning, everyone. Before we see patients, remember pre-rounding is where real ID thinking develops. So during round, senior ask questions rapidly, like a strong fellow already knows overnight events. You should know what has happened in your ward, about the cultures of the patient, antibiotics given, if there is any organ disinfection, source possibilities, stewardship opportunities. So today I will train you exactly how elite ID fellows prepare. So the step 1 is open the patient file correctly. It is 8 a.m. in the morning and it is your pre-round. Do not start from the culture report. Start from why is this patient in hospital. First identify primary disease. What is the primary disease that person is having? Timeline of the disease. What procedures have been done? Any devices if that person is having? Antibiotics already received. What all antibiotics he has received till now. So ICU patient for pre-round. So there is a example case. Current case is that 65-year-old male admitted for perforation peritonitis underwent laparotomy 6 days ago. Now, fever spikes are there, hypotension, rising TLC or meropenem plus teicoplanin. So, that was the perforation peritonitis is the person who he was having that, and then what procedure happened, it underwent laparotomy 6 days ago, and now he is having fever spikes, hypotension, and this all is going in favor of sepsis. So devices what that person is having, you have to check for that. Central line, Foley catheter, abdominal drain. So these three are there. Now your pre-round structure. Every ID fellow should review patient in this sequence. First, is the patient stable or deteriorating? So how can we check that? You should go for BP, the heart rate, urine output, oxygen requirement, vasopressors, lactate trend. So this all you have to check, and you know why for. Then because unstable patient changes urgency and empirical therapy. So you have to change it if that is not going in the benefit of the patient is not improving. If he is deteriorating, then first duty is, if you are on pre round, that either you ask your senior or you look for it and change it. Sorry. So coming to the fever pattern. So this was all about the, if you see the patient is deteriorating or if he is stable. Now you look for the fever pattern, that it is new fever, it is persistent fever, if it is fever after the initial improvement, or night spikes are there, or drug related timing. So if it is related to these type of things, then you look for it. Then fever pattern itself gives you clues, so you have to know all these things. Devices review. Now you have to review the device. So the most important in ICU is, if there is central line, then you should see since when you have started the person is using it, and whether it is still needed or not. So you will see the same thing for central line, Foley catheter, ET tube and drain. Now the infectious disease principle is, every unnecessary device is a future of infection. So don't use any unnecessary device, because more the devices will be, more will be the chance of having infection. Now coming to the antibiotic review. So this is mandatory in the pre-round. You should know which drug that patient is having, why it was started, what was the day of therapy, dose, renal adjustment if it is required, culture support. So whatever antibiotic you are giving, you should check the renal investigations and KFT RFT, so that you come to know whether everything is proper or not. Culture support, de-escalation possibility, if it is there, then go for it. For this patient, you should see why meropenem, why teicoplanin. If any culture evidence is there, can we narrow the therapy, because you are giving imipenems here. So these are broad spectrum. Microbiology review. So now open the cultures carefully. Today's reports blood culture, no growth till 48 hours. So in this time, if you see the blood culture report of this patient, you find no growth. Then drain blood culture, Klebsiella pneumoniae was isolated in this drain blood culture. Drain fluid was also cultured. Now resistant to ceftriaxone, resistant to piperacillin tazobactam, and then it is sensitive to meropenem. So the drain fluid which is showing Klebsiella pneumoniae, it is resistant to these following drugs and it is sensitive to meropenem. That is why meropenem is being given here. So does culture automatically explain fever? No. Always ask, is drain proper functioning? Any undrained collection, anastomotic leak, any new infection, or the fungal infection? Culture alone never finishes the case. So fifth point is that source control review. So most important ICU concept is source control. Where is the source of the infection? So ask, was pus drained? Any pus was drained? Repeat imaging done? Any residual collection somewhere in the body? Necrotic tissues are there, or the drain is blocked or not? So this is going to help you in getting the source. So remember, persistent fever despite sensitive antibiotics often means inadequate source control. Now coming to the laboratory trends, look at the trends, not isolated values. You see towards the trend. Now review TLC, platelets, creatinine, bilirubin, CRP or prolactin, lactate, and important is in this way you come to know about the other systems. So you should know all the systems are working properly or not, liver, kidney, everything. That is also very important. So that is why we are doing creatinine, we are looking for bilirubin and the other blood reports. Now CRP and prolactin, they will also tell you about the infection. Then important is falling inflammatory markers with improving clinical status. It may support de-escalation, means if you are giving broad spectrum antibiotic, now you should start with the narrow spectrum. So next point is think about the fungal infection. Very important in ICU, because the immunocompromised patient are there. So you should look for these things. So the risk factors here is abdominal surgery, prolonged antibiotics, ICU stay, central line. Always ask, could this be candida, especially if persistent fever is there, no bacterial explanation, TPN and abdominal leak. So pre-round assessment is, we have done this round and you see that example, you have to write everything, and post-operative intra-abdominal sepsis with persistent fever and shock, possible ongoing source, residual intra-abdominal collection or the anastomotic leak. So we should know what is the source of infection and what you get in culture, ESBL Klebsiella from drain fluid, meropenem sensitive, and what you need to evaluate, adequacy of the source control, repeat imaging, catheter necessity, possibility of fungal infection, antibiotic de-escalation data based on cultures and clinical report. So this is the language of the ID infectious disease round, what should be done? Now, seniors may ask you on this basis many questions can be asked. So, rapid fire question is like, why can meropenem fail despite the sensitivity? So, the possible answer is abscess, poor source control, or there may be biofilm, inadequate penetration, fungal co-infection, or the wrong diagnosis. So these may be the causes of the meropenem failure. Then which is more important, MIC report or patient condition? So the correct answer is always patient condition. We should not look for all these things. First we should take care of the patient. What is the biggest risk of prolonged meropenem? So think carbapenemase resistance, fungal superinfection, microbiome destruction. So what is the biggest risk of prolonged because resistance may develop. If you are going to give this prolonged treatment, then this may happen or fungal superinfection may take place or the microbiome destruction. So many teaching stewardship, if they want to teach you, then weak clinician. So patient if sick, then you add the antibiotics. What exactly am I targeting? Never escalate blindly. So if you have to escalate, if the patient is sick, what the person will do, he will just add the antibiotic. But if you are a good infectious disease fellow, then you have to see what you have to target, whether that antibiotic is sensitive or not. So your task before the next round is, for every patient who have come in the ward, you should under these headings like syndrome, uh, okay, you should see syndrome, source, organisms, current antibiotics, culture, devices, source control status, and then de-escalation possibility. So gradually you start doing the practice and you have to do this. So this is the first day, and then we will go for second day, what we can do on the second day. So this is for the second day.